Hi guys, welcome to week 7. I'm glad to see everybody here. Just please put your cameras on. Somebody's on a Zoom user, just so I know who you are. I can change your name if you know who you are. Oh, there you are. I see you. Just put your name on. How's everybody doing this week?
No. This is outside of that.
Good, bad. We made it to halfway, guys, so that's a good thing. We're at our midway point. So I was really happy with you guys for your scores on your test. We had 294s, which was spectacular. I'm really proud of all of you guys for working hard and getting yourselves ready for the test. So this gave us a good leeway into our 3rd exam, and then our 4th and final will be the exam at the end, which is the cumulative test. It's not an exam. You guys know what it is. I'm drawing a total blank right now, but your HESI at the end, right? So that'll be your 4th exam. So we have 1 left to go. I want to make an announcement for everybody. If you received a 78 or lower on this exam, I expect you guys to reach out to me and we'll go through the exam. Anybody who would like to go over the exam as well, I'm happy to do that with you. Just let me know when you're available and we'll go through the questions. What was your guys' impressions of the exam? Don't be too specific because we have 1 student who still needs to take it, but just overall, what was your thoughts?
Yeah, that makes sense that
We had good guidance for this one. The study sessions were really insightful and helpful. It was almost impossible to do like poorly if you attended those sessions and looked over the review, in my opinion.
Okay, good. So you thought the review was helpful. I'm glad to hear that. Any other feedback?
The questions were very to the point, like it wasn't broad, so it was straight to the point.
Good. Okay, I'm glad. And I think what you guys are starting to come to see is that you guys are getting more comfortable with the test taking and nursing exams. And so now you're like, oh, this type of question, this is how I have to do process of elimination. So I was happy to see that for a lot of it. We did test analysis. There were a couple questions that we gave back. I won't go over those in detail right now, but we did give just a few back. And I think for the most part, as a class, we did pretty well. So I'm proud of you guys for that and happy about that. So like I said, 78 or below, make sure you're in touch with me. I will go over the test with anybody who would like. So if you're interested, I can do that with you. Let's take attendance right about now. And I want to make sure we're all here. Jen A, I saw you somewhere.
I'm here.
Yep. Okay. And then Norma.
Here.
Ariel, I saw you. Thank you. Rox.
I'm here.
Great. And then McKenna.
Here.
Awesome. Michelle.
Here.
Thank you. And Jamie.
I'm here.
Courtney.
Here.
Tiffany I.
Here.
Leah, I saw you. And Tiffany L.
Here.
Okay, hello there. Kathleen.
Here.
Great. Erica. I let you in, so you should be here somewhere.
Yeah.
I'm here.
You're here. Thank you. Jen M, I saw you. Welcome. Pete, you here? There you are. Barbara.
Yeah, I think it's.
Yes, I'm here.
Great. Macy's here because she just put something in the chat. Great. And then Heather.
Here.
Okay, I'm going to rename you Heather. That's because I just have to.
Thank you.
Sure.
So we need to know what that is before, we say yes.
Okay. And then Hope.
I'm here.
Great. Tiffany, you're at the bottom there. Tiffany, turn on your camera if you can. Janice.
I'm here.
Great. And Priscilla.
Here.
I saw you somewhere. Great. Awesome. All right, guys. So we have almost the whole class here now. So I'm glad about that. All right. So we have 3 chapters this week. Next week, is a ton of chapters, but I'm going to give you individual reading on the chapters. So don't overwhelm yourself with all the reading for next week. I'll be specific on page numbers I want you to focus on. This week we're going to do, I'm sorry, my husband's in the background talking quite loudly. We're doing infectious disease, and we're going to do abuse and neglect, which is really sensitive to my heart because that is something that I see very frequently in my place of practice right now, unfortunately. But we will take a look at that. We're going to look at something called the ACEs study. I don't know how many are familiar with it, but it was a study that was done by Kaiser Permanente, and it investigates adverse childhood experiences, also known as ACEs. We're going to listen to a physician speak about it. She's pretty powerful. It really overlaps all our thoughts on community and neglect and abuse and how that impacts us long-term with health perspectives. And then we'll go into infectious disease. You guys have your stuff due tomorrow. Your discussion posts as a group due tomorrow. Responses are due Sunday, sorry. So please make sure everyone submits a copy. As far as the peer reviews, where that's part of the rubric, I know based on the way the groups have been handled and who's been in touch and who's been able to get it together and stuff like that. So don't worry about your peer responses. One of you guys sent me peer responses. I appreciate that. But for this quarter, we're just going based on what we know, and I will review that student who sent it to me, and that will be a part of the rubric as well. So I appreciate that, but not necessary. Any other questions about this week coming and what we're looking at for this week? We'll look at it at the end, but I just wanted to make sure.
So we're not doing the peer responses?
No, you don't have to fill out the peer response review papers. As a community, we decided you don't have to, but if you'd like to, do them. But what we've decided as a community, all the instructors are pretty much going based upon what we know about the group and how that works together. But
So
if
do
you
we
take-
still do 2 peer review responses?
Yes,
Oh,
I'm sorry. Yes. This has nothing to do with peer responses. It has to do with peer reviews. So that's
Okay.
part of the rubric. I'll pull it up in a second just to clarify for everybody. So by tomorrow night, we have our first initial post. By Sunday, we have 2 responses to 2 separate groups. Everybody on page for that? All right, and so then if you look at the rubric, which I'll pull up right now, let me pull that up so that we can look at how it is being graded. There's a section on there about group work. And what we had done in the past was have you fill out these peer review papers. But what we're doing to make it a little easier on everyone is we're not having you fill out necessarily the papers for it. So I'm just pulling up the rubric. I wasn't ready because I didn't think about this whole time. Let me look for that. I'll look for that in our syllabus. But anyway, so clarity for that one is 2 peer responses, APA references for your responses, of course, like normal. And we're gonna have that by Sunday. Any questions about the group project? I'll look at the rubric with you guys at the end, don't worry. All right, so the first thing we're going to look at tonight is going to be abuse and neglect, and we're going to talk about that. Anybody have anything that they'd like to share as before we begin this? Sometimes people have experiences or personal things that they don't have to say are personal or something they've seen. When you think about abuse and neglect, what kind of ages are we talking about?
It
I
could be
think
any
it's
age.
all age, yeah.
Very young and very old.
Good. You're going to have across the spectrum. So you'll even see teenagers, right? Think about domestic violence. When we talk about domestic abuse, you're going to have those right in the middle there. And we are always concerned about our elder abuse, as we know. So the first thing we take a look at is, I'm going to share my screen with you.
As a nurse for 15 years as an LPN, there's also sexual abuse with teenagers as well. I worked in a juvenile detention center where a lot of that went on, and that was definitely something that happens too.
Excellent. Thank you for bringing that up, because sometimes that's an area that we don't focus so much upon. the teenagers. But remember, our number one thing for teenagers for risk factors is going to be violence. And we talked about a little bit a couple weeks ago about the violence among teenagers. If they're new to relationships and they don't know what a healthy relationship looks like, they're going to think that this is normal, right? Because if they come from a home where there's abuse and then they go to a relationship where there's abuse, that's their normal, that's their standstill.
I was gonna mention that they call it like the cycle of abuse. It's
Mhm.
really powerful. Like, for example, like my parents and my mom specifically, my grandparents, they were like, my grandfather was really domestically violent, abusive, you know, he hit her a lot. There was a lot of violence in their home, and 3 of my aunts ended up with violent partners in their adult lives because of the fact that it was all that they knew. Like with my mom and my dad, it was a cycle that it was something that we saw her, and then as the 3rd generation, it was kind of like up to us to break the cycle versus becoming a part of it. And I think a big thing that helped us do that was the fact that we were in the US, because I mean, my mom and my grandparents grew up in Jamaica, where it's kind of more acceptable to see abuse and to be in that cycle. But here we're taught in school and we're given lessons on what is okay and what's not okay. And that's really what made the difference.
Good. Thank you for sharing. I think that culturally, we really look at that and see, Ariel, and I appreciate that because, you know, sometimes we do see it as cultural and we do see this cycle and this pattern that tends to repeat. There's always those people that are able to break the cycle, but it's kind of like addiction and things like that. There's people that are able to break cycles, and then there's people that are not able. And why that is not, you know, there's not enough scientific research out there. When we're looking at violence, we're going to look at mortality and morbidity. We know as nurses, we're going to care for victims, perpetrators. I had a recent experience where one of the nurses that I work with, he had to go into the prisons. He was part of another organization, had to go into the prisons, and because he was a male, he was the one who was assigned to give vaccinations to the sexual predators, because the sexual predators in the jail, what he shared, were not able to even have a woman give them a vaccine, or they would revert back to their behaviors. So it can be on a spectrum, you know, it can be something that's very obvious and very seen, and sometimes it's hidden quite a bit. So know that we're caring for the victims. We can be caring for the perpetrators. We have to take an active role in looking at our violence through work. Factors that are going to influence violence, you know, is work. Work causes a ton of stress for everyone. So when you have stress at work and then you come home and you're irritated or angry, might you see some violence there? Media has really portrayed, and we'll see this with female violence, they sometimes tend to make it look prettier or not as aggressive as it may actually be. I don't know if anyone's watched any of the movies. You know, there's one from a long time ago, and I only remember it because it was so famous, but it was called The Lady in the Burning Bed. And so that was a domestic violence movie. And she gets out of it. I mean, she gets away from it, but she sets the bed on fire. And so that's how that plays. But it, you know, I have to realize with media, the way it's portrayed and things like that, religion, population, and facilities, like Ariel just spoke about, was the population one that was violence is more the norm than the exception. And so something to look at when we're looking at our people. So when we look at work, we just described this, it can be, you know, frustrating, can cause violence elsewhere. Our education, schools have assumed many responsibilities. So what I can tell you being a school nurse is that if kids says in the state of Colorado, if a child says that they were hit, if they were not hit with an object, then that's not necessarily a reportable offense. And what you see is culturally, for some children, hitting is okay. So culturally, they believe hitting is the way to deal with children. So we look at that. I mean, think about violence with bullying and all of those factors. I'm going to show you what I spoke to you guys about, I think at this point, with kids and what we see with kids and abuse and neglect. Schools are places, big places where I spent a lot of my time reporting incidences to, you know, the Department of out here. It's called Department of, Childhood Services. And what that does is that gives a warning to them so that if they have several complaints about it, then they may follow up. What that really, the goal on reporting these kind of things is education as nurses. We want those people who are in abusive relationships or abusive situations to find a way to cope other than abuse. So it may not be that the child will be taken from the parent or will be taken from the domestic home, but a lot of times it's going to be that we are teaching them how to behave without violence. So let's take a look at this video, and she's a really, hold on, I gotta stop sharing and start sharing. It's a really powerful video. We're not going to watch the whole thing, but we are going to watch some of it. Let me move us.
The CDC and Kaiser Permanente discovered an
Okay, can everyone see it and hear it? Just give me a yes or a no.
exposure that dramatically increased the risk.
I don't know why it's blue. Hold on a minute.
Seven out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, "Dr. Burke, have you seen this?" In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed.
All right, we're going to stop sharing there. Has anybody heard about this study? Anybody have any research behind it or know anything about it? It's very significant when we're looking at children. It's that constant, if any adverse, and as you heard, 62% of the population has at least one. So if you look back, and when I first learned about this several years ago, I thought to myself, what kind of childhood experiences has my family had, or has my mom had a type of cancer? So I thought, she did come from an abusive home. She did come from, and so when you added up her ACEs, she was more likely to, and so that for me was just a way to understand sometimes. But when we look at it as nurses, we're looking at these children and they are vulnerable. And when they are exposed to neglect, abuse, whatever it is, it's that repetitive fear that they have to survive somehow. And so that's what she speaks of. I thought the study very interesting and really helps us understand the impact of neglect on children. There's nothing quite like it in the world that anyone could probably describe, and know that children are oftentimes, when we're looking at abuse and neglect, they're very honest. They don't know that what is going on in the household is not the normal. Just like we talked about teenagers with, and I use the word normal in parentheses, it's the lack of abuse or the lack of neglect. So I've had children say, oh, well, I was locked up in the closet last night. And so then you investigate, I've developed, and I think as nurses, we all know at this point, what do you have to develop in order for these kids to trust you?
Rapport.
Trust.
Trust, rapport, what else?
Listening.
A safe environment.
Yeah, safety.
Absolutely. And kids know right away whether it's safe or it's not based on what they're coming from, right? So anyone who's worked with children knows this. They know right away that you're a safe person, or if they can feel comfortable. You have to be really open with when we're looking at abuse and neglect, and regardless if it's a child, a middle schooler, an adult, a young adult, an old adult, you have to make sure that your therapeutic communication with them is key, because if they don't trust you and they're not feeling like they can tell you things, they're not really going to. So that ACEs study is something that you guys should really spend some time learning about, because this is how community nurses can pull in our med surge and look at these things. If they're having these things happen to them, what does that do to them long term? And so think about that when you're evaluating kids, young teenagers, adults, any of that. If we take a look at our PowerPoint, we're going to go back to our 25 PowerPoint. Hold on. And we talk a lot about kids and media, what they're seeing in the media and what they're normalizing. Abused women and rape victims are going to benefit from media attention if it's portrayed in the right way. You want to be careful with that, though. Sometimes it is not, as we just spoke about. We talked about religion, different populations. Crowded conditions do know that there's a greater potential for violence when it's crowded. Lack of jobs, low paying jobs, and feelings of inadequacy, despair, and social alienation can contribute to our factors as well. When we look at homicide, it's a killing of one human against another. We're going to see with Healthy People 2020, where we have a goal for homicide. Assault is going to be a physical or verbal attack, and suicide, we all know, if we're going to look to decrease that. We look at family violence and abuse. We spoke a little bit about this, where the patterns that we're seeing, there's physical, sexual neglect, child abuse, domestic abuse, and abuse of older adults. I wanted to share with you something about older adults. This is a great, several different examples of where we see abuse among elders. So hold on one second, I'm gonna share. I just found some really good stuff this week that I wanted to share about this abuse. And it really, I think sometimes rather than me talking to you guys about abuse, you guys are seeing it and hearing it in pictures. It's a lot more monumental.
Well, you can't. She's just not up to seeing visitors today or tomorrow. Well, it's just not possible. She's not seeing anybody, and she doesn't want to see anybody. No, not even you. You'll just have to wait until she feels better.
Ed, come here. I want that.
Now,
Ed!
now she's up again and calling me. I have to hang up. I'll call you soon when she feels better. Listen, Mom, you're just not in a position to have visitors right now. Maybe once you sign the documents, you'll feel better.
But I'm feeling fine.
Mom, we both know you'll feel better once you sign the house over to me. I just don't want you feeling overwhelmed with the burden of the house on your mind. All right. You might as well just go to your room then. Because we have nothing else to talk about until you...
All right, I'm gonna pause that for a second. What kind of things do we see there that look like abuse to the mom?
She's trying to gain control of her house.
Or just like yelling.
The isolation.
People from seeing her.
Yeah, the isolation is a big red flag. Abusers like to get you alone so that they have full control.
What does he do to her feelings when she says something?
Minimize them.
Yeah, kind of just says, nah, like that's not true. Be careful there. I like that you guys saw it, but the violence, you see here, the volume of his tone, you hear his tone. He's very dismissive of everything she's saying, right? Oh, you don't know. Oh, you can't have visitors. Now, I don't know anybody who has elder parents, but I can speak of having a 78-year-old father, and him and technology. Well, no, they sort of go together occasionally when I help him plug in the phone properly and stuff. But older clients, they're not like up on technology like we are necessarily. Some are really on it, but they're not necessarily, they didn't grow up with computers. They didn't grow up with cell phones. So something for us to consider. All right, look at this next one now we're going to look at.
Sign. And you're not seeing any visitors until this is sorted out.
Oh, I hate these things.
Here, let me do it. What's your PIN number?
1970, your birth year.
Hi, Gloria.
Oh, hi, dear. How are you doing?
It's not working. We'll try again tomorrow.
But Mom, you had money in your pocket.
Come on, I don't want to hear about money we don't have. Let's go. Come on, let's go.
All right, how about that one? What we see that were some signs that would alert us if we were observing that.
The lady, the older lady didn't even want to do it.
I'm sorry, say that again, Hope.
The older lady, like the grandmother, the mother, she didn't even want to be in this situation to begin with. And she made a comment like she hates this, like it's happened before.
Right, good.
Well, she tells the daughter, don't say anything. Kind of.
Right, what impact do you think that had on that little girl?
It's okay to lie.
It's okay to take money. It's okay
It's
to
okay to take
ignore.
from others, like selfish.
Mhm. What else did we see in that was concerning?
When she hands over the card.
What was concerning about that, Michelle?
That it seems like she always gives it to the daughter for the daughter to handle it.
Did anybody else pick up on this? And I found this interesting, and I don't know if anyone paid attention to it, but so she says, what's your pin, right? And then the lady, the way I heard it was the woman said 1917, the year you were born. And I was thinking, so this daughter already knows the pin, because obviously the girl's not, 105. So, there was something to that too. How much was the mom was she really, with it, or did she have some form of dementia or something like that? Anybody else see anything a little concerning in that?
She pocketed the money, but said it wasn't working.
Yeah, I mean, she pocketed the money. She stole the money flat out in front of the mom. Do you think the mom could have seen that?
No. She
Maybe.
could have, but she didn't.
I think she might have.
Even if she did, I think it's so bad. It's such a bad, like, it's so toxic that she wouldn't have said anything, because then she could be verbally abused.
Probably knows what happens. She just didn't do anything.
Doesn't want like
She's used
confrontation.
to it.
Right, and so she gets back in the daughter's car, because what else is she supposed to do? Right, even if she watched that all go on, what is she supposed to do? Stand on the corner and wait for somebody?
Yeah, she doesn't have any other
Option.
alternative
Yeah.
to go with her.
Good. I want you guys to pay attention on this one. Hold on one second. Pay attention on this next little clip we're going to watch about the environment. Go ahead. I'm sorry, whoever was speaking.
Also, just the way that she was like rushing them into the car, like the way she talked to them, like, hurry up, we don't have all day, kind of.
Yeah, pretty demeaning to the mom. Okay, here's one more. Pay attention to the environment and the people in this one. Oops, hold on. This is just a lady. We'll finish this up.
Mary, I'm hungry. Are you on your way out to the store again?
Oh, hey guys.
Oh, Phil, you're back. How was school today?
Oh, there's no school today, Gramps. Just practice.
Okay, I am on my way out. Dad, you stay comfortable. I'll grab some food and bring it back later.
But Mary, I'm hungry now.
You'll be fine for a little bit, Dad. I'll hurry, okay? Can you get your grandpa a glass of water and take him back to his room? Here, Dad, make sure you take your pill today too, okay?
I thought I already did.
No, and you missed yesterday too, so just take a couple of extra. He'll be fine, he just needs a nap.
What'd you say?
Nothing, Dad. Make sure to have a lie down. Okay, I'll see you guys when I get back.
All right, come on, Gramps. Let's go. All right. Almost there, Gramps. Almost there. All right, and yeah, there you go. There you go, Gramps. Let's go.
Wait, you're not gonna just leave him like that, are you?
He'll be fine.
I don't know, man. That just doesn't seem right.
He'll be fine. My mom gave him something that's gonna help him sleep for a while. Come on, we're gonna be late for practice.
You know what?
All right, we're gonna stop there. All right, so what did we see in that one? That lots of flags on that one.
Over medicated him in the daytime, gave him medication to go to sleep. His room has multiple tripping hazards. They're leaving him alone.
Dirty. Food all over the room. Who knows how old it is?
Good.
And
You
if
saw
he's
the
hungry,
pizza.
he's probably going to eat it because he said he was hungry and they dismissed it.
She has the windows covered
Mhm,
with pieces of board.
mhm. What'd you think about the grandson?
Well, he didn't do a
The
good
mom
job
was
putting it
that-
in bed.
I feel like
Good.
he's like so used to his mom doing that, like he probably thinks it's normal.
So what I really like about this one is this shows us the impact of abuse on everybody in the family. So the parent is doing something that she thinks is okay. The son, the young child in the last video, the older son on this past video, they normalize it because that's what abuse is. Oh, well, that's how you treat old people, and this is what you do. So we saw a lot of different things there. We saw financial abuse, we saw physical abuse, we saw emotional abuse. What else did we see with that the grandpa in the end? What other kind of abuse or neglect? should I say?
Neglect.
He just kind of just threw him on the bed and left him there. So he wasn't even positioned right on the bed. What if he got sick or choked or maybe had a heart attack?
Good. And remember the
Or
older,
medication.
yep, the older clients are not going to be as quick to respond, as quick to realize they're falling off a bed. Or remember, compromise the older you get, even what if his feet, he couldn't feel his feet. Maybe he had some neurological, thing going on from diabetes with his feet, but they just threw him on the bed. I mean, he could easily have fallen off the bed and had anything happen to him, right? Could have broken an arm, could have broken a shoulder. These are the kind of things we look for. Like if we're in the ER, when we have people coming in with unusual or frequent bruises or injuries or things like that, right? We always want to reconsider in our head, what is going on and how can we figure this out? I just like to show you those two videos. I know, because I feel like it's sometimes a little better than me talking to you about abuse if we see it. When we're looking at our book about abuse, I just want to pull up a couple sections. The Healthy People 2020 related to abuse and neglect. And we're going to look at where that is. So hold on one second. We are in chapter 25. I will share with you guys in just one moment. Chapter 25 is where you will find about abuse and neglect. So one important thing here is our Healthy People 2020. We know how important that is relating to reducing violence. So we're going to try to reduce those homicides that we talked about, firearm and bullying, child maltreatment, reduce violence by intimate partners, sexual violence, and child's exposure to violence. We spoke to and watched a lot about the ACEs study, and I want you to know about that. It's pretty important because it will long-term have a health effect on our children. One other thing I wanted you to look at is I highlighted some in the chapter just to help us, but oops. Box 25-1 is going to tell you about abuse and power and control. Abuser is going to frequently, not necessarily, but create that isolation like the old guy, the son did to the mother. Keep him away from people, from going to work or school, particularly jealous, possessive, and saying like, oh, you can't use your car, you can't go where you want. We're going to see threats. I'm going to hurt you or your family or your friends if you turn your back on me. I'm going to take your children away from you. I'm going to report you to welfare, and I'm going to hurt, I'm going to hurt myself. And so that's a threat that we look at. Intimidation, they're going to put you down, call you names, humiliate you, interrupt you when you speak because they don't want you to say anything to anyone. Oftentimes using the children, we'll see them calling bad parents or say the kids don't like you, or I'm going to take them away from you. Oftentimes the abuser will deny food or medical care. We saw that with the older man where they just like overdosed him. So it's not denying, but giving so much and really not even, it's just cruel treatment there. Sexual abuse, we're going to see that with sexual abuse, we will have sex will be withheld or affection, or they will say you're doing whatever I tell you and you're not going to use any birth control or any controls. when we look at a case study is what we're going to look at now with abuse, but I want you guys to really look at and think about potential child abuse, because kids will usually tell you things. That's been my experience, unless they've been trained not to. But usually the younger they are, they don't know to make up stories about what happened. You know, as adults, we learn we need to make up stories to protect our abusers. And sometimes older people are not going to make excuses either, because oftentimes they're around a healthcare provider that can help them. So when we look at those unexplained injuries, burns, I've had children come in with burns to their back, and their parents have actually put cigarettes out on their back. We look at biting, any trauma to the head, any trauma to genitalia, and you will get that with young kids. They will say, this hurts, this itches, things like that. Evidence of poor care, hygiene, unusual fear of others. That we talk about the nurse, but usually if you're creating that that important relationship, you won't see that. Any shown evidence.
I can't read that slide.
You can't see that one? Is it too small? It's in your book, so if you can't see it, I'll tell you what page to look at. I can. Is that any
Okay, if
better?
you could let me know what page. No, for some reason
It's
on my end, I can't read
Page
your slide.
444.
Yeah. It's recognizing. Thank you. So those different things that you're going to be looking for. So we highlight that in our book. And that's about, as far as the book is concerned, that's all I really wanted to focus you guys on, because we know Healthy People 2020, we always do. We're going to do a case study real quickly and see where our thoughts are with abuse and neglect. So here we go. Let's share this. Alrighty. Everybody should be able to see this. Yes. Okay. Anybody want to read the case study for us? Oops. No.
I'll read it.
Thank you.
Eliza Little is a registered nurse at a community activity center. The activity center provides daycare for working parents and sports and drama activities for youth. Nurse Little provides first aid care and health education classes for the children and their parents. Cole Donovan is a 5-year-old boy who stays at the daycare during the day while his parents are at work. Nurse Little has noticed that Cole frequently visits the clinic, often for a hug. Every time Nurse Little sees Cole, she notices a new bruise. At first, Nurse Little contributed this to Cole being an active little boy. However, as time went on, she became suspicious of the frequent bruising. When Nurse Little asked Cole about his bruises, he said he didn't remember what he did to get them. Once, when Nurse Little was letting Cole down after a big hug, his shirt got caught on a door handle, revealing several diagonal scars across his back. When Nurse Little asked Cole how he got the scars, he immediately looked scared and refused to talk. When Cole's mother came to the daycare to pick up her son, Nurse Little asked whether she could talk to her. Nurse Little explained how she discovered the scars and noticed the frequent bruises on Cole's arm. Nurse Little asked what it was like at home and whether Mrs. Donovan knew how Cole was injured. Mrs. Donovan was quiet for a long time and then whispered, "He beats us. He hurts Cole to hurt me."
Okay, so that's our scenario. First question, what are indicators for child abuse in this case? You can put it in the chat.
The bruises. Oh.
Or whatever, call it out, either way. Bruises, good, what else?
Bruises.
Varying
The
bruises.
way that he wants the hugs and the attention.
Yep, what else?
He's frequently in the nurse's office.
That's a big flag usually. Because going to the nurse's office a lot of times is a flag for bullying, a flag for needing some safe adult in their being. Okay, anything else that you noticed in the story?
He became very quiet, refused to talk.
And for a kid, that's a big red flag for you, because kids will always talk. So we said unexplained bruises, scars, and chapter 25 we just talked about, which we just looked at. All right, what community services could Nurse Little recommend and or employ for Cole or for Cole's mother?
A battered woman shelter.
Shelters, yeah.
Okay, you can certainly recommend to a shelter. Anybody have experience with women's shelters?
I do.
Yeah, I've done volunteer work at some.
And what have you found with the women in the shelters? Are they like excited to go to a shelter?
Absolutely not. Some of them, they come and then they end up going back. It's a few times. Most of the time, they never just come that first time and then break away. They'll come and then they leave and then they come back.
Yeah, that would happen with my experience, especially when they have children. They're more likely to go back to the abuser because they see the impact that being in the shelter has on their children.
Yeah.
And usually what is true about abused victims? What is in them that makes it hard to walk away?
That battered woman syndrome that they talk about, that where they kind of feel like it's what they deserve because they've been told that it's their fault for so long.
Or
a lot of
dependence.
times, and a lot of times they feel like they need to protect the abuser, or in some instances, like she was saying, it's financial. Like if they walk away, a lot of times they lose total control of like finances. They don't work, so they feel like, well, what am I going to do if I leave?
There's a tremendous
Also-
amount of fear among someone who is being abused. There's fear for all of these things. So good, go ahead.
Sometimes they feel like they can help the abuser too. Like they can help them get better.
And usually they think they can fix them, because they've
Especially
started.
because
Go ahead.
there's periods during the abusive relationship where the abuser can be like the sweetest person on the planet. And they feel like that there's that person deep inside. They don't realize that it's part of the cycle.
Good. All right, so if we look at services, this is what we're looking at. So we could call Child Protective Services. Remember I was telling you guys that Child Protective Services their purpose is not to take children away unless it's an unsafe environment. It's a lot of education that can go on. We have Parents Anonymous. You guys spoke about a abuse shelter. There's community support groups, 24-hour hotlines, those kind of things, and victim assist programs. What can Nurse Little do to prevent violence at the individual or family level?
Give them resources on how to get out, like social services, the different hotlines, shelters, things like that.
Good. What else can a nurse do to prevent violence?
On the individual level, since the child is technically her patient, she would have to like call CPS and focus on getting him out of the environment before she can get the mom help, because it's going to be harder to get the mom to leave the environment since she's an adult and she's in a relationship with the person, but they can intervene for the son easier.
Okay. Just for clarity on that, nurses are not able to take a child from the home. So you'd have to involve, if you think it's that unsafe, if the child you do not believe is safe going home at the end of the day, you need to call, law enforcement for that.
Wow.
But what else could we do to prevent violence at the individual or family level? I was hoping somebody would say, how about primary prevention? But nobody did. So it's really, the question is asking you for what you could do to help stop it. Not in this case scenario, but in this case scenario, what level of prevention is necessary?
Education.
Tertiary. Tertiary.
Yep. Is there already being?
Because the abuse is already happening.
Oh, so you mean like primary prevention outside of this situation?
Yes. So remember the question asked. Now this was I like this question because it says, what can Nurse Little do to prevent violence at the individual and family level? It says nothing about the case scenario we were discussing, right? This is an outside question to have you pull in your primary and secondary prevention.
Oh, okay.
Does that make sense? So I did this particularly because for test taking purposes. Like, if we can be talking about a case scenario and then address that, but then when you talk about something at the individual and family level, at this level with this particular family, there's not a whole lot you can do to prevent the violence, right? Because it's already occurring. What are we going to do with our tertiary prevention? What is the goal of that?
Try to make sure no further abuse happens.
Stop the abuse.
To minimize, to minimize the complications from the abuse. So here where there's not a whole lot, I mean, it's tertiary prevention in that but we're not going to be able to prevent it from occurring because it's already occurred, right?
So in other families, you would focus on education and like counseling for couples would be important, and teaching them how to properly discipline their children within a means where it's not getting to the point that it's violence. Like a big thing is talking to kids, and if they're too young to understand being talked to, then they're probably too young to understand why you're hitting them. I read that was like a big thing that you can teach.
Yeah, and you're going to teach children, you're going to teach adults, you're going to teach everybody stress reduction techniques so that the kids are not throwing things around the room. Maybe they're not abusing people, but they're certainly, mistreating toys or something like that. So even on a little child, you can teach stress reduction. We're going to take deep breaths. We're going to breathe together. We're going to draw pictures. We're going to color some, those things. So keep in mind that you can do stress reduction at any age, and parenting skills obviously is going to go to the level of the parent and the developmental needs of the child.
There's that documentary about Gabriel Hernandez, which was like really eye-opening. I watched one time on Netflix.
I'm not familiar with it. But
it's really
need to watch it.
It was scarring.
It's crazy. Like the abuse in the system, and I think it was out in California is where it was based at.
It was. I saw it too. It was. Oh my gosh.
It was scarring. I had to pause it.
It was crazy.
Breaks.
Yeah.
And is it a documentary? Is that what it is?
Yeah. They prosecuted the social workers because they let him fall through the cracks.
They failed the boy.
Yeah. And that's the thing about for our campus in Cutler Bay, we've been volunteering at Patches, which is like a pediatric center. And there's a child there who's been being abused by her grandfather, and the mom is abusing them as well. And the mom is being abused by the grandfather, and the kids came out addicted to cocaine and stuff. And CPS is trying to work with her to get the children back to her, which is it's so hard because when you think about it, there's this fine line with DCF and CPS and social work, because the goal is to keep the family unit intact. They preach that, and they try to do everything they can to educate parents and get them to the point where they can be good parents. But with this documentary, it shows you the line where it's where do you as a officer of the law know when you can no longer get through to these parents and you have to do things differently.
When you've tried so many times and it keeps failing. When do you take that next step?
It's really hard.
Ideally, children are supposed to be with the parents, and that's what they go for. But there are situations where you've tried so many times, you're okay, this isn't feasible.
Right. Yeah. And I think that's a good thing to bring up, and I'm glad I'm going to watch it. Gabriel Hernandez is the name.
Yeah, it's really eye-opening.
And the hardest part of being a nurse in this, Leah, just 1 second, the hardest person in being
the school teacher was the biggest advocate for that child.
And sometimes you are the biggest advocate, and you only have so much say as a healthcare provider. Leah, go ahead.
I was just going to say there's a series on Netflix called MAID, M-A-I-D, which is a true story. It's an excellent case study on the domestic violence abuse cycle and the lack of resources, poverty, and going back and trying to get out. And it was very good.
Yeah, and that really probably would be a great case study.
Yeah,
for us
it
to
was
look
great.
at. Yeah, it was a book as well, I know. Thank you.
I don't know if I can handle the Gabriel Hernandez one. I've read a lot about it. I don't know that I could emotionally.
That show really broke me. There's that show, and then When They See Us on Netflix, which was about those 5 kids
that was a very good.
Shows I literally had to take breaks from. I had to pause it and breathe, because it's so hard to get through it. And I think it's good that we're seeing it in television and on the media, because like you get a viewpoint that you didn't get before. Because when I was a kid or when I was growing up, you didn't see stuff like that. It was like we didn't talk about it, we acted like it didn't happen. And now we're putting it in the limelight and we're making it mainstream so that the little kid at home watching it can say, hey, wait, that's happening to me. And they're saying it's not right on TV. Maybe I should say something. And that's important.
Yeah, and the sad part is that I would hope kids wouldn't watch these kind of shows. But if they're being neglected, I have firsthand experience. Their parents are not paying one bit of attention to what they're playing or watching. I have a kindergartner who told me he watched Squid Games or whatever the other day, and I thought, whoa, like that's powerful for a 5-year-old to be watching, right? If anybody's watched it, I only watched the first like 30 minutes because I couldn't stand it. But you know, it was just so remember that when you're looking at kids and what they're exposing themselves to, it could be a ton. So I appreciate all that input. And neglect and abuse, you can take classes on it. It's just horrible, but it's a part of our world and a part of our clients. So I need you to remember that across the spectrum. And we do see that repeated. All right, we're at 7 o'clock, so I'm gonna let you guys have a break. We're gonna just, before we take the break, we're gonna come back and do infectious disease, and then I'm gonna have you guys do like a little work on your own, and then we'll come back together and go through that. So that's what we have for the rest of the night, but I'll give you guys 10 minutes. So let's come back at 7:10, and you guys turn off your cameras, do whatever you want.
My drop spins on rifle have gotten so much better than they were when I first tried out for rifle.
Why is my teacher calling me? I'm on a Zoom.
Calling you?
Yeah.
Answer.
No, because I.
And tell her that you're on a Zoom.
Hello? Hey, yes, it's me.
Your mic is off.
Pretty good.
To me.
Mute your mic.
Thanks, guys. Just everybody stay muted because we don't want to hear phone conversation. Sorry about that, guys. It was a little late coming back. All right, I'll wait for everybody to come back.
I have an interesting story about an overzealous person. Do you want to hear it?
Sure.
So this is about 25 years ago. My son, he's about 7, and it was late evening, and he was sick. We had to take him to the hospital. So we took him to Children's here in Dayton. And it was like October time period, so right between football season and season were overlapping. And the nurse just checked him out, and he had these bruises all over him. And so she asked, told her, of course, she didn't believe him. She actually called the police on me and my wife, and called CPS. So we made them call our doctor, our family doctor, who's taken care of my kid forever. And he lives up in Greenville. But he's also a sports medicine doctor. He called one of his other sports medicine doctors that Dayton and children, and looked and told the nurse and the other doctors there these are all related injuries.
Do they believe you? Him?
Yeah, they believe this. Who, the doctor?
Yeah, did the doctor who spoke to the other doctor believe the doctor?
He finally did, because he's a sports medicine doctor. He's seen injuries and seen bruises and stuff. They were all consistent with playing football and wrestling. But that nurse got in trouble for it.
Oh, really?
Yeah.
See, it's a fine line too, because she's looking out for bruises, and it's hard in an ER, I think. I mean, what do you think, Pete? In an ER, it's kind of hard to say, this parent looks fine, right? Because then you'd feel like, well, what is look fine? You know what I mean?
Oh, I wasn't throwing a big fit. They were wrong, they were crazy and everything. I didn't do anything to get out of line to make them see this guy really is. Like that, I let them do their thing, and in the end, I was going to win.
Yeah, and that's I like that though, because in the end, if you haven't done anything, there's no reason to feel guilt, right?
Yeah, I had that happen to a friend of mine. The similar situation, except her son is on the spectrum, so he does a lot of like violent behaviors towards himself. And she took him to the hospital because he fell off of his high chair and hurt his arm. But he had bruises and like different healing stages, because when he gets like meltdowns, they call them, he hits himself and he slams his head against walls and stuff like that. And they got CPS involved. She went to jail and everything. And it was like a whole thing where she had to basically fight for her son back. And in the end, it was that she didn't do anything, It happens. It's hard because you, as a nurse, you have these 15, 20 minutes to try to make a decision on whether or not if something's going on. And it's like, I think it's always safer, to be wrong than it is to be right and have not said anything. I think that that's important.
For sure. And there's a lot of guilt that goes with that if something happens to the child, because if you know something, that's why you're called mandated reporters, right? Because if you know something, it's like knowing anything.
When the sports medicine doctor came and looked at my son, he brought the other doctor and was going over the bruises and everything with him. He said, there is no hand marks, there are no fingerprints, there are no lateral lines for like a belt or a switch or anything like that. Yeah.
Sure. And it's hard. I mean, that's a fine line, because I've had kids that have belt marks on them, and the child will say, oh, well, it was me and I hit myself on the door. I mean, and you can see the buckle, and so it's really hard, because kids, if they know enough, they won't say anything. And if you know what I mean, so it's really hard. But being in that situation, Pete, you know what that's like. So it creates a sensitivity, I feel like, for you when you're approaching the topic, which is sometimes our life experiences help us as nurses to, approach topics differently. All right, we are going to start on infectious disease. You guys should be pros at this by now, because you are doing your group presentation. I'm going to have you share a little bit about your group presentation. On our PowerPoints, which I'll share with you guys, after the class. We're just gonna take a look really quick. Oops, let's go up here. We're gonna look at, we have a worldwide concern with infectious disease. Everyone knows this. The bigger that our world grows, the bigger they can travel. Okay. We're also looking as people move from one place to another, levels of immunity and resistance to diseases and viruses may appear that have not previously. If anybody's familiar with measles, had an outbreak maybe 4 years ago. The reason for that is because we have a lot of people coming into this country that are not vaccinated because they don't need to be, or because it's not mandated or whatever. So we started to see that virus pop up in our country. So just remember, when we're doing that kind of thing, when we're looking at infectious disease, we're looking at where all these people coming from. We look at our historical, where it came from. Our complex 1900s, we saw these leading cause of death in the United States. By 2000, we had improved nutrition and sanitation, vaccines, antibiotics. So this is going to help our endemics and our epidemics. As people live longer, we see chronic diseases are replacing infectious disease as our leading cause. But other things are taking over. We have just had a virus that traveled tremendously. COVID was all over the world. We saw its agent, we saw the host, we saw the environment where it existed. Remember, we're looking at our modes of transmission, how they go back and forth. You can have vertical, so I want you to think of it up to down, from mom to baby. So it's going to be during childbirth usually, or through breast milk, right? Horizontal will be person to person. So if we're like moving down a line, it can be direct or indirect. We have a common vehicle, which means that the host can be in water, milk, blood, saliva, plasma. And then we have vectors, which are going to be like our ticks and our mosquitoes, and how they are going to bring in some infectious diseases. So I put this picture in here. You have an infected person, a healthy person. Direct contact, you can have sexual transmission, you can have transmission by hand, that COVID they believed was by air. Indirect contact, it would go on an object, and then if you take that object, by food, by insect, and by rabies. Anybody think about what's an infectious disease that can be spread by indirect contact?
Hepatitis B.
Okay, tell me why.
It's the one virus that can live outside of the body on surfaces for up to a week, which is one of the primary reasons why in healthcare they try to get you to get vaccinated against Hep B, because it's very resilient. It takes a lot to kill it.
Good, very good. It is killed by some of the wipes that we have out nowadays, but yes, there is that indirect contact. How about a food? What's one of the ones with food?
E. coli.
Salmonella.
Salmonella.
There's
another hepatitis that's by
Hepatitis A.
Yep, Hep A. How about our insects? What kind of things are we gonna have?
Cockroaches.
Lyme disease.
Lyme disease is a big one.
Zika.
Mm-hmm.
Zika.
All right, good. Remember, and this takes us back to last or the week before last, about surveillance. We're always going to be looking at a good surveillance system for these kinds of things. And we look at with bioterrorism particularly, and we have state by state is reportable. So depending on the condition, you have to report it to the state and then they will follow it. So that's how we survey for the most part. We have some emerging infectious disease, but I find this funny because it says West Nile virus on here. And so this is before they even knew that COVID was coming out. But anyway, Ebola, H1N1, that's old at this point, but remember our book's 2018. When we look at our preventions, our primary prevention, we're going to seek to reduce the incidence of disease by preventing it. So what kind of primary prevention for infectious disease can we do?
Like, for example, hand washing, or like, for example, with COVID, where we did lockdowns before people started getting sick so we could prevent the spread.
All right, if we're preventing the spread though, how did we prevent the spread? What did we tell people? What did we educate people?
Social distancing, masks.
You said another really good one. Hand washing. I don't know if anybody has a relatively new Apple Watch, but they now count 20 seconds for hand washing on there. So that's a good one. Our secondary, what kind of things will we do for secondary prevention?
Get tested.
Yeah, we can screen for it, sure. What else are we going to be able to do? We're gonna do who is our vulnerable populations. We're gonna make sure we're screening those. And then tertiary, remember, we're gonna work to treat whatever it is. So we have a whole section in our book about agents of bioterrorism. And this is where I'm going to let you guys do some research. I will tell you that all of the information that I'm asking for you in this is in your book, so it should be in your reading. What we're going to do is we're going to split up into groups like we do, and we're going to do a jam board together. Remember, our jam board will be looking like this. Hold on one second. Our jam board will look like this. Let me share my screen. Okay, here's our jam board. Remember, here on the left side, we click on sticky note, and this is where we put our information, right? So one group is going to be doing anthrax, one will do smallpox, one will do botulism, one will do chlamydia, and one will do syphilis. Okay, so we'll have 5 groups. I'm going to share the link with you now. In our chat, I'll put it in there. Okay, and I'm going to split you into groups in just a moment. What you're going to find out for us, and you're going to share back with the class, we're going to do signs and symptoms. Why is it a threat to the community? I'll type it in the chat for you guys. Why is it a threat to the community? And what can we do as health nurses, community nurses? What impact does it have? Does it have, sorry, I'm typing as I'm talking. Does it have on the community nurse? And what interventions can be done? Okay. Any questions? Most of this is in your book in chapter 27. Okay. And 6, there's a bit on 26 as well. All right, so I'm going to break you out into rooms. You guys remember how to do the Jamboard? Did everybody get on it? All right, so group 1, you're doing the first 1, 2, 3, 4, 5. Got it? So we're doing 5 groups. Here we go. Tamika, you want to go to one of the rooms? Maybe. There you are.
Let's also do like body stuff, like they said, like blisters, scabs, and ulcers.
Yes. So blisters, dark scabs, small bumps, and ulcers. And swollen lymph nodes.
Yeah, that's true. Yeah.
Mm-hmm.
Right. What's the next thing that I'll
Okay,
look at?
so we'll do that for signs and symptoms. Then the next one we have to look up is why is it threatening to the community? I mean, it's respiratory, so it's like very high infection rate or like
Yeah.
a maybe transmissible rate.
It's spread really easily.
There's a nice chart in your book that I'll tell you about the threat to community. It's on page, let me look. Chapter, yeah, you're chapter 26. Let me just look real quick.
Okay, so that's chapter 20.
You guys are doing anthrax, right?
Yes.
Yes.
Why is it?
Last paragraph on page 427.
You got that, Courtney?
Got it.
Before smallpox, right before it says
Okay.
smallpox. Okay,
Thank you.
Thank you.
sure. You guys seem to be doing well, though. I'm gonna leave you. Hey there. You were in a breakout room, but I know you said your internet's iffy. So you want me to sign you again? You're muted.
Yeah, I got booted out. I was supposed to be in group 1. I don't know if they got however many you needed in there, but
Yeah, I'll put you in one. There you go. Good.
Who haven't been vaccinated. And then for like the tertiary, I mean, that would definitely affect them, and the fact that they would have to give the vaccination.
It doesn't sound like the vaccination is just available to everybody though, because it says that it's available through the CDC.
Yeah, so which that could also like be an issue too, like the whole that's also like a community nurse issue also, like people not having access to it. So it's like trying to provide access, or I mean, that's the same way with education.
I think the access is just controlled by the CDC for an outbreak would be.
For what?
Be used as it's the vaccine's controlled.
Indirect.
Yeah. So it's easy to catch it. So I guess that's
Yeah.
why it'd be community.
Spread easily through.
Spread easily, yeah. It's easily spread.
Yeah.
How are we doing here?
Indirect? I think we're doing okay.
Good. How are we doing here? You guys are quiet.
I'm still trying to find syphilis in the book.
Yep, it's in chapter 27.
I'm still trying to find that.
I'll find it for you. Hold on.
27. Because I only found it in one spot, but it didn't really talk much about anything.
Yes, same. It just tells us like the stages of syphilis, basically.
I think it's a vertical transmission. That's the only thing that I found so far.
Nope. So are you looking at chapter 27?
Yeah.
Hold on. I got there. If you go to page 445 in your book. You guys see it? There's a couple paragraphs on it. If you have any problems with, go ahead.
I found it. For some reason, my computer was stopping at like page 443 and was saying that was the end of the chapter. And
Oh,
I had
that's
to
weird.
actually click in through there. So I don't know why I did that. Okay. I
Okay,
found
so
it.
yeah, 445 should help you guys.
beside me, and that's like a big thing.
All right, guys, we're gonna end in like 60 seconds, okay?
Yeah, we're good.
Okay. Hey there, we're
More stuff to stress about.
60 seconds, good?
Yeah.
Yeah.
All right, guys, we're gonna end in about 60 seconds. Okay.
Okay. What can we do as a community to prevent it?
So, all right, guys, we're gonna end in about 60 seconds.
Okay, thank you.
Thank you.
Oh, I already told you guys.
Prevent would be making sure that all of our vegetables and our
All right, it looks like we have returned, but it doesn't look like we have the whole class back, so I don't know what's going on. Just give me a second. All right, I'm gonna take quick attendance. You guys don't have to call it. I'm just gonna, because we have to have everybody here for the whole class, and I've noticed that sometimes people check out early, so we can't really have that. It's not fair to the rest of us who stay on the whole time. So let me just take attendance on who's here. All right, Janice, you're there. And Tiffany L. And Norma. And Hope. Leah. Ariel. McKenna. Michelle.
Oh, I put my name in the chat earlier because like you just never call my name because I guess because I was put in the morning class, but I just put it there.
Thanks, I got you, Abby. So Roxanne, come back, right? Jamie, you here? Tiffany Iyer, yep, you're right there. Heather, did you come back?
Yes, ma'am.
Okay, great. And then Tiffany Rose, no? Okay. Alrighty, guys. So our first group, let's look at our Stuff, our anthrax group. Okay, go ahead. Anthrax group. Who
So
wants
we
to
had
tell us?
anthrax. I had Ariel, Tiffany, Ellen, Courtney in our group. Signs and symptoms were fever, chills, chest discomfort, shortness of breath, headache, hypoxia, body sweats, blisters, and then it gets more severe when you start getting scab, ulcers, swollen lymph nodes. That's when your body's really trying to fight something off. It's threatening to the community because it's highly transmissible, and it affects large amounts of people quickly. It's very quick to spread. It can kill quickly, and then the pandemic of the public can cause a lot of anxiety and a lot of commotion. With the nursing impact, it definitely causes a burnout for nursing because it is very overwhelming when you have a high caseload coming into the clinic where typically they probably wouldn't see, as many people. So they would need to have, their PPE supplies, treatments. They would need to be ready for a pandemic, very similar to COVID with it being respiratory. And then interventions would be IV antibiotics. And there's also a little sticky note for some ones that they listed, but they are Cillins. So you would want to look out for allergies. You would want to get medical care quickly because it is very progressive. If you end up on a ventilator, oxygen support, you'd want to be on vasopressors. And then there is a vaccine that they did mention. And then there's also a sticky note here about some testing specifically for anthrax versus other respiratory issues that, you might look at first.
All right, and when do we see anthrax? Why was that popular? I mean, not popular, but
I want to say it was like 10 years. What was like George Bush? Like,
yeah, it was September 11th is when we saw
Yeah.
anthrax on
10 years ago.
envelopes and
Early
stuff like that.
Yeah, that's what I was thinking too.
Terrorism. Yeah, bioterrorism.
Yeah, that's when we really saw that kick in.
Yeah,
It'd been going on for a while, but that's where we see it. All right,
And we
good,
don't see
good
it
work.
much now. It's kind of diminished a lot now.
For
And the
now.
vaccine is available
yeah.
for military workers, government employees, people that are more likely to come into contact with it. not
Overseas
for the
back and forth
public.
and stuff.
Yeah.
Good, good. All right, smallpox. Here's another one. Who's our smallpox crew? Well, somebody had to work on it. Anyone?
For smallpox, the signs and symptoms are kind of flu-like. So you can have a sudden onset of fever, prostration, severe body aches, occasional abdominal pain, and vomiting. The threat to the community, it could be used as a bioterrorism threat, and it is 100%, you're 100% susceptible to it if you're not vaccinated, which people aren't now. It's not a common vaccination that's given out. And the transmission can be droplet, airborne, or skin to skin. And the other concern is that there's freezers with smallpox in Russia and at the CDC, and people are concerned that if somebody got their hands on it, that shouldn't be, that they could expose a large group of people. We said that the impact on the community nurse would be treating the infected with, you could have shortages of PPE, the risk of exposure to those who are caring for the infected, and interventions would be education, vaccination, the importance of isolation guidelines, and prompt reporting of signs and symptoms. It also said that the community nurse should be educated on how to differentiate between smallpox and chickenpox. And then we did primary, secondary, and tertiary. The primary, there should be education on the importance of hygiene. Secondary, testing for the smallpox or identifying it. And tertiary, if there was an outbreak, managing it and getting vaccines from the CDC.
Good, and I like that overlap that you spoke about with chickenpox. Smallpox sometimes is confused because they appear similar. All right, important because smallpox is highly spreadable. It can be used as a terrorist activity as well. All righty, botulism.
For the signs and symptoms, we came up with weakness, blurred vision, fatigue, trouble speaking, weakness of the arms, chest, and leg muscles, vomiting, diarrhea, and abdominal swelling.
Good.
What was the next one? Why is it a
Threat?
a threat to the community? It's because it's easily spread through direct or indirect contact, and it has a 7.5% risk of death.
Okay.
Interventions is, I guess the impact of the community nurse. It's difficult to trace to see where the originated from. Airborne precautions are required since it can spread through the air, food, and water. And it's difficult to treat everyone who is affected in an outbreak since care is intense and can be on in a ventilator for weeks and months if they survive.
What have we learned about airborne precautions? Given COVID and communities and all that.
It's highly transmissible.
Yeah, airborne spreads quickly, but what else do we know about it?
Negative pressure environments. You have to have like that full gear, and you have to have pressurized air because once you breathe in the air from the environment, you're at risk.
What have we learned about face masks? Which we all kind of know, but
They say it reduces exposure.
It's going to reduce exposure, but what is true and what have we found with COVID and face masks?
People aren't willing to take those precautions.
They may not take the precautions. What else do they do?
I think it weakens our immune system further because we're not exposed to anything.
It can. But what do we know about face masks? There's
People don't
so
wear them
many that
correctly.
we have been using. And what is true about COVID and the spread of COVID? What is the only mask that really prevents it?
N95. Because
and people are wearing t-shirts over their face saying it's a face
Or
mask.
cloth masks and stuff, or bandanas.
Yeah, it needs to be able to block the air filter the air. It needs a filter for the air before it can be considered safe.
Yeah, so see, this is why this can be a huge problem. Because you put people in face masks, or so what they think is face masks. This is a good example. Okay, and what do we do as community nurses? I like this as well.
Treat signs and symptoms.
Yeah,
I think we're starting to write it and then it disappeared.
No, you can treat the signs and symptoms. Of course, any nurse can do that, right?
Yeah.
Good. All right, next one is chlamydia. This is going into our section on chapter 27, which is sexually transmitted diseases. One of the groups did HIV, so you guys should be fluent on that. I'll send the PowerPoint in chapter 27. We're not going to have the time to go over, but I wasn't going to spend a lot of time on it because you guys are already doing it. So chlamydia, what can you tell us about it?
So the symptoms vary, men versus women. Men, it says 90% are usually asymptomatic. And then those that do have symptoms, the only one we could find was inflammation of their urethra. Women are usually symptomatic and they have symptoms such as, painful urination, urinary frequency, vaginal discharge, bleeding or pain with intercourse, and bleeding with menstrual periods. That's heavier.
Okay, good. Why is it a threat to the community?
Because it has very serious complications, and it's usually affecting younger women, like pelvic inflammatory disease, ectopic pregnancy, infertility. If somebody gets pregnant with chlamydia, it can affect the child. It can result in complications. And, because we're also seeing that it's actually increasing in the recent years.
Because of diagnosis and reporting. So good, because if the symptoms are mild, they may not be reportable. They are reportable, but they may not report them. Good. And how about as a community nurse?
So this was kind of shocking to me. I didn't know. It says 1 out of every 20 women ages 14 to 24 has chlamydia. That's 5% of women in this age group. So that's a pretty big number.
Good.
And I think also because it's something that we can prevent through education. So it should be something a community nurse can focus on, especially since, it's the younger adolescents and, college age students.
Good. And what are we going to be teaching them?
Protection. If you have intercourse, abstinence, of course, is always best. Avoiding multiple partners, signs and symptoms as well. If you know, just in case they get it, so that they can get proper and prompt treatment so that they're not spreading it.
Great, awesome. Good work on chlamydia, and then syphilis. We had a little bit of hard time, but then we found it. So let's tell us about syphilis.
So some of the signs and symptoms are rash on the palms of your hands, soles of feet, fever, fatigue, sore throat, hair loss, weight loss, swollen glands, headache, and muscle pains. But there's also 3 different stages. There's first stage, which is primary, secondary, and tertiary or late. And all 3 of those, they all have different signs and symptoms. It's a threat to the community because those that are not affected, if they are affected and not aware of the infectious disease, it can spread with partners and increase the STD rate. And it can also pass through the placenta. So it can be passed through to their babies. And the book does say that if it's untreated and it's passed through birth, it can cause stillbirth, blindness, deafness, facial abnormalities, crippling, or death in younger kids. Some interventions are primary would be educate on safe sex with adolescents and college students. Secondary would be screening for it, and tertiary would be treatment. The main treatment is penicillin, but if they are allergic to penicillin, then they have doxycycline or tetracycline as alternatives. And then the impact it has on the nurse is the nurse could get it through contact with a sore that the patient has if they don't know that they have it and they're doing like a physical exam or anything like that. If the nurse comes in contact with it, then the nurse could also get it. And then it could cause an outbreak depending on how people interact with each other.
Good. And nurses here in this one, they're going to be doing a lot of educating to young kids for prevention, abstinence, all that kind of stuff. It's really going to have an impact on a community nurse in a school setting, in a community setting, a community health setting, whatever it is. Okay, good work, guys. All right, you guys covered most of what we would cover about infectious disease and all that. You have chapter 27, which does HIV, syphilis. There's a couple other ones, hepatitis, those kind of infectious disease, which you guys should be kind of fluent in from med-surg. So not a big deal there. Let's take a quick look at what's due this week. Please do not forget Wednesday. I'll pull up our syllabus. Wednesday is your assignment. Everyone needs to hand that in. I had one group reach out to me and get some help on the writing. What I will mention is the headings. That paper that I gave you when you did your professional development plan, that was a good baseline, those little headings. So like you would put a heading at each separate section. So like signs and symptoms, treatment, like that kind of thing. That would be a heading type thing. Make sure you guys are citing your sources. That's important. There should be no information on there that is not cited, because none of this information is knowledge from your brain. It's from med-surg book or from med-surg class or something. Any questions on that? No? Alrighty, let's look at our week, and then we will, like I said, I will send out your PowerPoints when we end class tonight, and I will also take a look at your live lecture attestation, which is due tomorrow. Let's see what it asks us. When discussing family violence, what are signs of abuse? We talked about that. 4 emerging infectious diseases. You'll find that in 26, chapter 26. But we talked about some of them. All right, any questions? 2 responses by Sunday, group discussion by Wednesday. Yes, good. All right, guys, have a great week. Enjoy, stay warm, stay safe.
You too. Good night.
Good night.